Hello everyone, I am Manali Reshamwala, Assistant Professor from LG Institute of Physiotherapy. Today I am going to talk about tracheostomy and tracheostomy tubes, which is a part of syllabus in final year BPT of subject physiotherapy in cardiopulmonary conditions in Gujarat University. To understand this, first we need to understand what are the airways. Here is a figure shown for normal airway versus obstructed airway. The air being passed through nose and mouth, then to larynx and pharynx, to trachea and towards the lungs. If there is an obstruction in midway, then patient will not be able to breathe properly. For that and to keep the airway patent, we require some instrument. There can be either oropharyngeal airway or endotracheal tube or tracheostomy tube. First we will see in brief about oropharyngeal airways. Oropharyngeal airway is being usually found when patient is in ICU or just he returns from operation theatre, so that a physiotherapist must know how to handle this, and it is usually made up of plastic material. It also is helpful for a physiotherapist to do suctioning easily for unconscious patient. Endotracheal tubes is next to progress. If patient is not being able to maintain its patent airway, then endotracheal tube is being inserted, and the benefit of endotracheal tube over oropharyngeal airway is that we can also attach ventilator along with this tube. It can be passed either through mouth or through the nose. These endotracheal tubes are also available in cuffed and uncuffed forms. These are being held with a bow-shaped cotton tape around the neck, but this is usually given for temporary purpose only. If we allow patient to keep endotracheal tube for longer period of time, then there will be inflammation and ulceration of the larynx. And to avoid that, after a week or so, that is by 7 days, we need to take a final decision whether a patient requires tracheostomy or not. And if patient requires tracheostomy, then an ENT team or experienced surgeon will undergo for tracheostomy tube. So if there is further requirement of airway, then tracheostomy is performed about 7 days. What is tracheostomy? It's an operation usually performed under general anesthesia. On skin there will be a vertical incision, and in the trachea there will be a small horizontal incision, which will be known as opening or stoma inside the trachea. And that tracheostomy should be performed at the level of second or third or fourth tracheal rings. If here we can see the tracheostomy incision made in the trachea. If the tracheostomy is too low, the tube may extend beyond the carina, and it will prevent air entering in the left lung, as right bronchus is more or less straight. And if it is too high, then there will be chance of subglottic tracheal stenosis. When a surgeon performs tracheostomy operation, then ET tube remains inside the place even during operation, and sometimes a ventilator is also attached to it. Once the tracheostomy is done, and there will be a stoma in which they insert a plastic tracheostomy tube. After that, gradually they will remove the ET tube. The plastic cuffed tube is commonly used. There are varieties of tracheostomy tube which we are going to see today, and here we can see the part. It is a straight arm here. There is a right angled flange over here, which will prevent the tracheostomy tube to go inside the trachea, and there is a small tube running around, and is a pilot balloon which we are going to see in few minutes. Here are the parts of tracheostomy tube, and is again tracheostomy is secured in a position of cotton tape fashioned in a neck around a bow. Types of tracheostomy tube. One is cuffed tracheostomy tube, in which we can see there is a cuff around the tracheostomy tube, which provides a good seal between the trachea and tracheostomy tube, so there will be no air escaping from here. And that pressure should be in a medium range. If it is too high, it will create a reduction or ischemia around the wall of the trachea, and which may cause ulceration. Okay. And we can inflate that cuff through a syringe, and we can see the pressure and the pilot balloon. Here is a one-way valve inside, and through syringe we can insert, and we can see that whether the cuff is inflated or deflated. And as I said, the care must be taken. It should not be overinflated or less. We can check it whether it's a perfect seal or not through stethoscope. We can keep a stethoscope just beside the tracheostomy tube and listen if there is a hissing sound. If there is a sound present, that means the seal is not proper. We can also check pressure by using portable pressure gauge, which will help to record the pressure inside, and it should be normal, should be 25 millimeter Hg. And even though there is a soft seal, we should release this cuff at certain intervals in patient. Next type is the cuff tube, which also allows to speak. As I said earlier, that if there will be a seal in the trachea between tracheostomy tube and trachea, the air will not go towards the larynx. That means in vocal cords there will be no air, and if a person does not get air in the vocal cord, how he can speak? So to allow the patient to speak, there is a pit tube available which has fenestrations over here. As a physiotherapist, we have to teach patient when to block the tracheostomy tube and allow the air to pass through fenestration towards the vocal cords, which will help the patient during expiration. It will help to speak, so that patient can also express their problem, situation, and whatever the feelings he is feeling. But sometimes if patient is too weak, this will not give good result. Here is the mechanism shown how patient can speak. Another type is silver tracheostomy tube, which is kind of a permanent tube which patient have to go along with it. It is usually seen in patient who has undergone for laryngectomy, and these tubes usually can be kept for some time, and after that there will be a fixed stroma which is being fashioned in a patient, which is a firm track from skin to trachea, and there will not be much difficulty in changing the tube by himself. Here is an example of silver tracheostomy tube a patient is carrying. What are the functions of ET tube or tracheostomy tube? One, it facilitates access to pulmonary secretion. Second, it prevents substances from mouth to enter and soiling the lungs, so there will be no chance of inspired pneumonia. Then to help the patient maintain positive pressure ventilation by preventing air from escaping around the tube, and bypass and obstruction preventing ventilation. It is also being said that because of ET tube or tracheostomy tube, there will be reduction in anatomical dead space, but it is not so, as the patient who requires ET tube or tracheostomy tube will already having some physiological problem in the lungs. So there will be obviously a reduction in physiological dead space, which will not come across with anatomical dead space. And disadvantages. One thing is tracheostomy or endotracheal tube bypasses the upper airway, almost half of the upper airway. There will be loss of humidification and increased danger of infection. We can reduce it by keeping the tracheostomy care and by giving humidified air and not allowing dry gases to pass, as they may cause crust to form in the block and may cause blockage in the tracheostomy tube. How we can take care of tracheostomy tube? We must clean up the tracheostomy tube to prevent blockage and increase risk of infection. We should use washed hand. We should put on the gloves to prevent infection. We should do suctioning regularly around the tracheostomy tube area before deflating the cuff, And through the tracheostomy tube we should also clean up the stoma and skin around it, and we should check the cuff pressure at least once each day. Here are the references. Thank you.